Thank you, organizer, to giving this opportunity. So today again, will be discussing role of chemoimmunotherapy post osimertinib progression in EGFR positive patients. So as we all aware, ki osimertinib is now one of the first, is one of the preferred option in EGFR mutated tumor among all the available option. But again, after over a period of time, we see these patients develop resistance and start progressing. And on progression, this is the one figure from article published in ISMO in December 21. You can see that there are some on-target resistance, there is some off-target resistance mutation, and sometimes we will not be able to find some resistance. So these are the three major group we can see. And this is a short summary again from the same article. These are the currently ongoing studies which are evaluating the role of the different kind of in combination with EGFR or either alone depending upon the mutation seen or in combination with the EGFR and immunotherapy, the further line of therapy. And out of this, currently we will going to discuss the ORCA trial. So this ORCA trial is basically a phase 2 study, multi-arm and multi-center. So, and they have basically divided their patient in the three groups. One is where they have found the again targetable mutation after the progression on the osimertinib, and second group where they have found mutation but it is non-targetable, and third group was there was no any mutation and they were treated with the standard recommended treatment. So basically they had almost approximately 7 arm in this phase 2 ORCA study. And out of this we will going to study the role of chemoimmunotherapy. The immunotherapy is basically Durvalumab. So they have included patients who had progressed after the first line osimertinib, and on progression there was no any detectable resistance mechanism or for whom biomarker directed study treatment were not available. And they have the regimen was Durvalumab 1500 mg IV along with the standard dose carboplatin AUC 5 and pemetrexed 500 mg per meter square every 21 days for 4 to 6 cycles. And after this, the maintenance with Durvalumab 1500 mg IV plus pemetrexed 500 mg per meter square every 4 weeks. And this will continue till the disease progression or until unacceptable toxicity. And the primary endpoint of this study was the overall response rate, and the secondary was PFS and duration of response, and there were safety endpoints according to the CTCAC version 5, and there was some exploratory endpoints which included tumor mutation burden and molecular aberration on NGS of the tumor samples and their respective correlation with clinical response. So coming to this baseline demography, so you can see that there was they have found 25 such patients, and the median age was around 61%, with majority were less than 65 years, and there was a predominance of female with there was more of non-smoker, and histology was predominantly all patients were adenocarcinoma. And majority had a high disease burden in the form of more than 3 or equal to 3 metastatic sites. And the common mutations at the front was exon deletion 19 or 21 and 790M mutation, and very rarely other mutations. And few patients, means approximately 1/4 patient had brain metastasis, and very rare patients had liver metastasis. And they divided patients who received osimertinib for less than 12 months or more than 12 months, and the majority were 70% patients were treated with the first line osimertinib for more than 12 months. And so as of the data cutoff, the more than 75, among all patients, 75% relative dose was given to this patient, and 22 patients had stopped treatment when this analysis was performed. And median treatment duration was 5.3 months for Durvalumab and pemetrexed, and to around 3 months for carboplatin, and the median follow-up was 9.7 months. So this was the progression-free survival at 6 months. Only 37.5% had disease progression-free, and with the median progression-free survival of 4.8 months. And coming to the response rate, you can see that the response rate was partial response was seen only 3%, 3 cases, making this as a 12%, and there was no any CR. And stable disease was seen in 17% patient, means 17 patients out of 25, making it 68%. And 4 patients had disease progression. Approximately 16% patient had disease progression on treatment. So there was partial response was seen in only 3 cases, making this as 12%. Coming to the duration of response, so median duration of response, patient who had a partial response was 12.2 months, and the duration of treatment in all patients, you can see that irrespective the first line osimertinib, whether they have received for less than 12 months or more than 12 months, there was no any correlation with the further chemoimmunotherapy response rate or duration of response. So even those patients who had less exposure to osimertinib had shown similar kind of response to the further durvalumab along with chemotherapy. And coming to the safety and tolerability of this regimen, so they have not found any new red alarm signs. So common side effects were more than grade 3 or equal to grade 3 was neutropenia and anemia. And that was also seen in small group of patients, 20% for neutropenia and 12% for anemia. Only one patient had a significant nausea for which they need to stop the carboplatin, and there was no any death in this study. And coming to the exploratory endpoints, so the tumor mutation burden was overall very low in all patients. And the NGS has identified that common mutation was TP53 or some EGFR amplification or EGFR, secondary EGFR mutation which was non-targetable. And there was no any association between the best response and EGFR sensitizing mutation type. So coming to the conclusion of this study, so as per the statistical criteria, there was a less than 10% chance of objective response of more than 45%. So this study was stopped, and it was a negative study. But they have shown that this regimen is tolerable, and there was no any safety alarm. So and the biomarker analysis is still ongoing. So ARCO study and the remaining of the remaining 6 arm of this ARCO study is still ongoing. So coming to my take on this study, so this data was consistent with the known fact that the mutated EGFR NSCLC patients are showing a very poor response to the immunotherapy. So whenever we see such group of patients, we should these are the unmet need of the unmet need of the patient. So clinical trials should be the option, and whenever we see such patients, we should refer these patients for clinical trial. If clinical trials are not available, then only our standard of care should be platinum-based doublet. Thank you.